Okay, perfect. Hello, everyone. Thank you so much for coming today. Before we start, how are you guys doing? I know the exam 2 is coming. It's just in 2 weeks, I think. But the second exam, it will not be that bad. It will not be as hard as the first exam. So we just have to cover the material, study the notes from the tutor, from the notes that you guys had in lectures. Like I told y'all to recording lectures and like literally write down everything he said. From those notes, I'm sure you guys will be okay. So this is the attendance QR code. Please sign in, scan your phone and sign in the code. It'll be really nice. Okay. So today we will be going over renal disorder. This chapter, mostly the content is like from Med-Surg 1. We have like some news, pathologies, some new disorder that we need to know, but mostly the basic knowledge is from Med-Surg 1. Like we have to know like the normal ranges and the lab that associate with the kidney. So the overview is that people, when they age, the older they get, the less function the kidney work. And then hormones, different hormones like the renin hormone, erythropoietin, like the hormones that the kidney regulate. AKI is acute kidney injuries. Pyelonephritis is a disorder that we will discuss today. It's basically like a UTI. Glomerulonephritis and nephrotic syndrome. It is very important that we know the difference between glomerulonephritis and nephrotic syndrome. And of course, obstructive uropathies, meaning like anything that obstruct the flow of the urine after the kidney produce the urine. So before we start, I thought about some of these. So can someone tell me like what is the normal level of creatinine and what does creatinine really means? I think it'll be helpful to kind of know the basic of some of the lab and some of the word that we're going to talk about today before we started. So I appreciate if someone can put in the chat or unmute and talk and tell me what is the normal level of creatinine or what do they think the meaning of creatinine. Okay, I'm gonna wait one more minute. Okay, so I have no response, so sad. But so the normal level of creatinine is 0.6 to 1.2. This is crucial that we need to know this level because in the test, in the HESI, they will be putting on the level of creatinine and we need to be able to tell, is it outside of normal range? Is the patient kidneys functioning? Creatinine is the main lab for kidney function. So the creatinine lab indicate kidney function. Okay, as simple as that. 0.6 to 1.2 and creatinine indicate kidneys function. If the higher the level, the worse the kidney function is. And then GFR, I guess I'll go ahead and tell you guys as well. So in Med-Surg 1, we learned about GFR. So GFR is basically like the rate of blood flow through the kidney. That is what GFR means. And usually above 90 is good. And below 15 will be will require dialysis. That's really long dialysis. Okay, and this is worded wrong. Not normal urine output accepted. Urine output is anywhere 30 mile per hour. Okay, and then normal BUN level is 6 to 20. This is the normal level. So this is a little bit basic about kidneys from message 1, that it is crucial for us to know and remembers these lab numbers and know kind of what it means. So GFR means the rate of the blood flow through the kidney. So the lower the GFR, meaning that the kidney is not well perfused, and if the kidney is not well perfused, it will not produce any urine. And then if it's not produce any urine, all of those toxic in the body, which is supposed to be excreted via the urine, will stay and retain it inside the body and causes all these problem, all these issues for the body, like acidosis and everything. So the lower the number the GFR, the worse. The higher the number of the creatinine is the worst. So as BUN, the higher the number of the BUN is the worst. Okay, everyone's good? Okay, next we have age-related changes. So the older, like I said earlier, the older the person get, the worse the function of the kidneys. So when we get old, we lost the glomerular function, which is the biggest change. The kidneys decrease in size, either because of atherosclerosis, all these fat plaque that obstructed the blood flow to the kidney, or poor health management. We eat too much salt. We don't drink our water. We dehydrated, and genetics. Bad perfusion. We use cocaine. We use stimulant drugs that causes vasoconstriction of the blood vessel. All these stuff can lead to decreased kidney function. And then aging structure, the bladder, the pelvic floor in women weakens from babies, prostate enlargement in men, BPH, weakening of the sphincter. Okay, so atherosclerosis equal decrease in renal blood flow, decreased GFR. Women result in more UTI and incontinence. Men result in hesitance, retention, and infection. So the reason why women usually has more UTI than men, because the length of the ureter. The ureter in women is much shorter than the ureter of a male. Therefore, the shorter journey for the bacteria to travel to the kidney or to the bladder and causes UTI. Okay. Next, we have kidney function. So the kidney function, it's regulate water and sodium. And it help with waste removal. It remove ammonia, potassium, and hydrogen. Hormone that the kidney regulate include renin. Renin is related to blood pressure. Erythropoietin is related to the stimulation of the red bone, of the bone marrow to produce red blood cells. Vitamin D. So if we have a acute kidney injury or a decreased function of kidney, from these three hormones, we can tell that it will affect the blood pressure. It will affect the patient. It will causes the patient to be anemic because of the decrease in production of erythropoietin, and then it can causes issues with bone fragiles and fractures because of the deficiency in vitamin D. So vitamin D regulates calcium, and if we have low vitamin D, it means we have low calcium, and therefore we will have high phosphorus, because calcium and phosphorus have an inverse relationship. All right, next we have hormone pathophysiology. Renin helps control the pressure. So like I said, no renin, it will affect the blood pressure. It will decreases the blood pressure. The renin hormone help the blood pressure constricted. But we don't have the renin hormone because the kidney doesn't function as well as it should be. So the blood pressure will be decreased. Renin hormone helps with the conversion of angiotensin 1 to angiotensin 2. ADH, antidiuretic hormone, regulates water and bicarbonate absorption. PTH regulate calcium and phosphorus. Parathyroid hormone. Aldosterone regulates sodium and potassium. AMP increase sodium excretion. So I would suggest we learn focus on the thing that in red, which is the renin hormone. It will decrease blood pressure, and when blood pressure is decreased, the perfusion is not as strong, so the kidney doesn't get perfused. And when kidney doesn't get perfused, it will go to injury. No erythropoietin means low H&H, causes anemia, and not enough blood going to the kidneys to perfuse. So again, it all leads to the no perfusion of the kidney, AKI, acute kidney injury, as the end result. Next, we have no calcium. No calcium will cause elevated phosphorus, and elevated phosphorus is damaging to the kidney. So also it will result in AKI. So a treatment for no calcium is we give calcium to keep the phosphorus low. Again, renins help regulate blood pressure. Aldosterone increase sodium, decrease potassium, and this will lead to edema. Okay, so acute kidney injury. So we talk this whole time about acute kidney injury. So what is acute kidney injury? Acute kidney injury, basically, it will have 4 phases that it will go through. The first phase is initial injury. So it begins at the time of the insult, continue to until sign and symptom appear. After, when the sign symptom appear, the patient will go into the second phase, which is the oliguric phase. In the oliguric phase, it's kind of the name kind of tells us, oliguric meaning no urine. No urine. So no urine is produced, or very little urines are being produced. Therefore, it will lead to fluid and electrolyte imbalance. When the urine is not produced, the water is retaining inside the body, and as well as all the toxins and the bad stuff that we don't want, that should be excreted, stay in our body. It will cause a fluid and electrolyte imbalances. And oliguric means less than 400 ml a day. So less than 400 ml a day. So like earlier I said, the accepted urine range is 30 ml per hour. That is the minimum. So if we do 30 ml per hour, 20 hours should have been 600 ml already, and 24 would have been 720 ml already. That is the minimum. But in the oliguric phase, when the patient is in AKI, they will produce no more than 400 ml. So this is the hallmark of the oliguric phase. We need to know this so that we can tell whether the patient is in the oliguric phase or not. So less than 400 is in the oliguric phase. Next, we have the diuretic phase. Diuretic phase is when the kidney is a little recovered, so it's produced more urine. However, it's still not returned to how it was before. but it's better than when it was in the oliguric phase. It's starting to produce urine. And finally, the kidneys will enter the recovery phase. This phase can take 1 to 2 weeks or up to a year. So we see improvement of the lab, the GFR will increase, BUN and creatinine will decrease. Okay, so the major diagnostic test due to check for obstruction in renal system is ultrasound. So I put this one here is because it is an important thing to know. So the major diagnostic test whenever the patient does, so when we in the hospital, if the patient doesn't produce urine, the first test and the most diagnostic test that we will use is the ultrasound. And then we do the bladder scan to see if there are urine remaining inside the body, the patient bladder. And the reason this is the better test is because there's no dye needed for this test. We all know that the dye is very, very damaging to the kidney. Okay, so remember AKI can be caused by pre-renal, intrarenal, and post-renal. So what we're going to do is I'm going to explain this in a bit. What does pre, intra, and post means? So AKI, again, I just repeat this. AKI has 3 phases: oliguric, diuretic, and recovery. Less than 30 ml per hour or less than 400 ml per day means the patient will be in AKI. The patient is experiencing acute kidney injury. So if the patient isn't peeing out fluids, what happened to the body? Where's that fluid? The fluid is retained and causes sign symptoms like distended neck veins, bowing pose, hypertension, edema, and heart failure. The body is then in a metabolic acidosis state because the body isn't getting rid of acid. For example, urine is acidic. We will then see sign symptom of acidosis like respiration, which is the rapid and deep respiration. Then we have fluid and electrolyte imbalance. We have hyperkalemia because the body is holding on to potassium. We need to watch for the heart as well, because when the body is holding on to the potassium, the hyperkalemia and anything that out of range of the potassium will cause damage to the heart. It will cause dysrhythmia. And then we will have hyponatremia because there's a lot of fluid in the bodies that dilutes sodium, and also the body is excreting sodium because damaged tubule cannot hold the sodium. So we have to watch for the edema. And edema could result in cerebral edema. Cerebral edema is too much fluid, too much swelling in the brain, which can cause pressure to the brain and leads to decreased level of consciousness. Hyponatremia is also because the kidney doesn't produce any urine. So we retain all of those fluid that we drink or enter our body. And therefore, the sodium in our body is get diluted, like we're pouring too much water into the little sodium that we have in our body. So therefore, we causes hyponatremia. Diuretic, think of the word. It means to fluid moving out, peeing. Problem with diuretic is that the body is getting rid of fluid rapidly, so it's not concentrating the urine and can lead to hyponatremia, hypokalemia, and dehydration. Might see hypovolemia and hypotension. That part is talking to the diuretic phase. Recovery. So if the kidneys are starting to recover, what you will see, we will see increased GFR, more than 125. Earlier I said better than 90 is good, which is true. Better than 90 means that the patient is normal, but optimum kidney function is more than 125. Below 90 is bad. Below 90 is a no-no. And below 15 of the GFR, meaning that the patient requires dialysis. Decreased BUN, it will stay in the range of 6 to 20 or 10 to 20. and then creatinine level is stay in the range of 0.6 to 1.2. And the earliest indicator of AKI is the creatinine. That's why we have to know creatinine is the lab that indicate the function of the kidney, and this is the range of it. Okay, next we are going to discuss the different causes of AKI. Like earlier I mentioned, AKI causes include pre-renal, intrarenal, and post-renal. So what is pre-renal? Pre-renal is the blood not going to the kidney, everything above the kidney. So pre-renal basically is low kidney perfusion. The kidney doesn't get the blood or the oxygenated blood that it's supposed to get, and therefore it leads to acute kidney injury. So before the kidney, these are issues with perfusion, decreased kidney function, decreased amount of blood goes to the kidney to be filtered, leads to kidney deprived nutrients. This eventually will lead to intrarenal injury, where those nephrons in the kidney become damaged and quit filtering like they should. So inside the kidney, we have these workers, which are the nephron, help us filtering and help us producing urine. When the kidney doesn't receive the salary, which is the blood, the oxygenated blood with the nutrients, they will go on strike and eventually will lead to issues internally inside the kidney. No nephron, no worker willing to work anymore. So therefore the kidney will be going into acute kidney injury, and they will quit filtering, they'll quit producing urine and serving the function that they're supposed to do. So some risk factors, some issues that may lead or cause pre-renal injury include cardiac issues, heart does not contract properly, weak ventricle will lead to decreased cardiac output. These, for example, myocardial infarction, heart attack, bleeding, internal or external. So when we bleed, we lost blood. And when we lost blood, we decrease cardiac output. And decreased cardiac output will lead to decreased kidney perfusion, and decreased kidney perfusion will lead to acute kidney injury. Okay, so also when we have diarrhea and vomiting, this also causes dehydration and hypovolemic. So when we don't have fluid inside the body, the blood viscosity, it gets so thick that the perfusion is not happening, and there's not enough fluid inside the body to perfuse the kidney, and it will also lead to pre-renal. So as well as burns and shock. So anything relating to the perfusion of the kidneys means pre-renal. Does that make sense? Am I going too fast? I hope I don't put y'all asleep. Okay, next we have intrarenal. Intrarenal is the injury inside the kidney. Okay, so injury inside the kidney include damage to the nephron, problems within the kidney itself. So intrarenal injury means that the kidney function, the kidney itself is being injured. Decreased ability to filter the blood. This will lead to decreased ability to filter the blood, remove waste, lead to excessive waste build up, increased water retention, unable to maintain electrolyte imbalance. So what causes intrarenal kidney injury? This include nephrotic drug. So NSAIDs, which include aspirin, ibuprofen, antibiotic, aminoglycoside, vancomycin, chemo drugs, contrast dye, infection, include glomerulonephritis, injury to the kidney. So it is so crucial that we need to remember this. We need to remember which are the nephrotic drugs and which antibiotic that cause severely damage the kidney. So we have to keep an eye on that when we give to the patient, or when the patient have kidney issue, we won't give those antibiotic. Those antibiotic are called aminoglycoside antibiotic, and they are usually end in sin. So no sin for kidney. Vancomycin, or other antibiotic that end in sin, we do not give if the patient having kidney injury. So yes, like I said here, causes include nephrotic drugs, aminoglycoside, and in sin, bad for kidney, example, vancomycin, tropomyosin, any antibiotic that ends in sin could cause kidney damage. NSAID is very bad for the kidney, for example, ibuprofen. Also, contrast media, wrong type of blood transfusion will also lead to hemolytic. Cross injury, like we have a person who punched the kidney or we fall on our stomach, we can also cause injury to the kidney. The most common cause of intrarenal injury is acute tubercular necrosis. So this is very important. We need to remember this because it will be on the exam. Acute tubercular necrosis. We need to know what it means, and we need to know that it is the most common cause of intrarenal injury. All right. Oops. So C is post-renal injury. Post-renal injury is pretty, the name can kind of tell us that after the kidney. So basically everything after the kidney. Most common cause is mechanical obstruction. This can include BPH, which is prostate gland got too big. Locate below, because the prostate gland, it locate below the bladder. So when it's too big, it leads to the obstruction of the urethra in the middle. So it put the pressure onto the urethra, and leads to not enough urine coming out and retention of the urine. And whenever we have retention of the urine inside our bladder, it will lead to UTI. Okay, so earlier I mentioned acute tubercular necrosis, which is the most common cause of intrarenal injury. So what does it mean? It means intrarenal condition that cause ischemia, nephrotoxins, or pigment sepsis. Risk factor of acute tubercular necrosis include shock, sepsis, prolonged hypotension, blood transfusion reaction. ATN is reversible, and causes of ATN include ischemia secondary to hypotension, hyperperfusion, which is shock, sepsis, dehydration, or direct damage from the toxin include radio contrast dye, for example, from CT scan, or gentamicin, which is the aminoglycoside antibiotic, or NSAIDs, ibuprofen or aspirin. Management include IV fluid to perfuse the kidney and stop the nephrotoxic medication. All right, so here I have kind of like a stages of kidney, the one that we went over earlier. I made a table for you guys so that you guys can kind of look over it in your own time. So this more detailed and clear. So I put it there for you guys to study, okay? Those are very good resources. So take a look whenever you guys have time. You're welcome. Next, we going to go over AKI treatment. AKI treatment include critical care, treatment precipitating causes. So we treat to the cause. We treat the whatever cause, either pre, intra, or post. We treat the cause, and it will help us with the treatment for the AKI. If patients still able to diuresis, we give fluids, then we give diuretic. This is important. Only the patient able to diuresis, meaning only the patient able to produce urine. And what does it mean, the patient able to produce urine? It means that their amount of urine produced per hour is more than 30 ml per hour or more than 400 ml per day. That means that they are able to produce urine. And the treatment is for those patients is we give them more fluid and we give them diuretic to help them pee out more. If the patient is in oliguric phase, which is the phase where the patient doesn't produce urine or very little urine, less than 400 ml per day or less than 30 ml per hour, we cannot give them fluid and diuretic because this can cause harm to the patient. So it's important when you guys do the exam, read the question carefully, which phase the patient is in order to provide appropriate treatment. Because if we give fluid to a patient who are oliguric phase, they will just retain the fluid more and more, and it will cause more swelling and cause more hyponatremia and lead to cerebral edema and other issues with the fluid balance. Okay, so nutrition, we need to decrease potassium because when we pee, we excrete potassium to maintain the optimal level of 3.5 to 5 inside our body. So if the kidney is not functioning well, it will retain those kidney because we doesn't pee out. So that's why we need to decrease potassium, because we already, when the kidney is bad, the potassium is high. We also need to decrease sodium phosphate in their diet. Make sure they get adequate proteins, intake of 0.6 to 2 gram per kilogram per day. Monitor potassium level. So give the patient insulin. So if the potassium level is out of range, is too much, more than 5.0, we give them insulin. Insulin can help regulate and bring the potassium back inside to the cells. Or we can give them sodium bicarb, which should bring sodium back into the cells. Or calcium gluconate, help to stabilize the myocardia so that we won't have an ECG. So this is a really good material for a SATA question, select or apply question. How can we regulate the potassium level? We give insulin, we give sodium bicarb, we give calcium gluconate and K-oxalate. K-oxalate is a laxative. It helps with patient poops, help put out potassium in their stools. If there is not an improvement, after we've done everything, we will put the patient through dialysis and CRRT for 2 to 3 days. All right. Next, acute kidney injury care. So this is just a repeated of the slide that I made. Fluid resuscitation and then restriction, treat elevated potassium. So the same material. For low vitamin D, we can put phosphate binder and vitamin D. Remember, phosphate is phosphorus. It has an inverse relationship with the calcium. So whenever we low vitamin D, we have low calcium. So a way to treat that is to decrease the phosphorus level. It will bring up back the calcium level. Then we have dialysis, which is a temporary treatment, and kidney transplant. Elevate potassium because the decreased urine output from oliguria phase. Always keep in mind of sign symptom of electrolytes. For hyperkalemia, insulin shift potassium back into cells. What kind of insulin do we use? We use regular insulin, so please remember that. Phosphate binder, bind the phosphate to help excrete them out. Teach patient with bad kidneys to avoid NSAID. What is NSAID? Aspirin and ibuprofen. So it's important when we study NSAID, but we have to know what is the specific of it. And then magnesium-based laxative and antacid. Kidneys can excrete magnesium very good when damaged. So we need to report the provider about weight gain, change in urine, increased blood pressure, shortness of breath, edema, increased fatigue, and weakness, confusion. If the patient suddenly gain a lot of weight, it means that they are retaining fluid inside the body. So it's important to report it. All right, so pyelonephritis. This is a intrarenal injury. So like I said earlier, pyelonephritis is kind of like a UTI. So let's see what that really means. So pyelonephritis pathophysiology include inflammation of the renal parenchyma and collecting system. Some part of the kidney is infected. So causes include UTI left untreated or gone bad, bacterial infection, E. coli, neurogenic bladder, diabetic mellitus, older patient because bladder does not work very well. So basically the UTI from the bladder. So we have the two kidney and then the bladder and then the genitalia. So when we have a UTI, it will affect the bladder first. And when the UTI move from the bladder to the kidney, it called pyelonephritis. So infection of the kidney causes by a UTI left untreated. Does that make sense? And then clinical manifestation include flank pain, chill fevers, lower back pain, fatigue, caused CVT. Yeah, guys remember in the health assessment class we do this. This is to assess for the CVT. If the patient experience any pain when we do this behind the lower back, it means that they are having some issues with the kidney. Need to check out. Commonly from a bacteria starting from the urethra that goes up to the kidney. Neurogenic bladders, patient has to cath themselves. High risk for infection. Obstruction in the urethra can cause backflow and cause infection. Pyelonephritis diagnostic include urinary analysis, complete blood count, care, urinary analysis, and scan before starting an antibiotic. Oh, urinary analysis and cultures before starting antibiotic. We need to start spectrum antibiotic after the culture. Do not wait for result. It takes too long. If you wait too long, sepsis can occur. So this is crucial to remember because we never want to do a culture before, after the antibiotic have been started. We have to do culture before the antibiotic. And right after we get the culture, we immediately put them on broad spectrum antibiotic to help them. And then after we have the result from the culture, we then can use a specific antibiotic to target the specific bacteria that was found in the culture. Fluid NSAIDs. So remember, we give fluid when the patient is in the diuresis phase. We don't give it if the patient is in the oliguric phase. Now, NSAIDs, again, aspirin, ibuprofen. Proper hygiene, urinary analgesic include pyridium, turns urine orange. We need to teach them this. So usually pyridium is a medication that usually a lot of female who have UTI use because it's help with decreasing the pain. However, this medication has a side effect of turning the urine to be orange. So we need to teach them this so that they don't freak out. Complication includes urosepsis, ESRD, end-stage renal disease. That's what that stands for. Treatment includes antibiotic and fluid. When we give fluid for a patient who have pyelonephritis, which basically means UTI, it helps the patient pee out and flush out the bacteria. NSAIDs help with pain and decrease inflammation. Proper hygiene. Teach them to wipe front to back. Make sure that they are cathing right if they have a neurogenic bladder. Complication can decrease kidney function from renal scarring and can be life-threatening. Treatment include give antibiotic because left untreated could lead to sepsis because remember untreated infection and become septic. Yeah, just remember the treatment is give antibiotic, I guess. All right, next we have glomerulonephritis. So it's a long name, but basically it means that it is an inflammation of the glomeruli due to immunologic process, inflammation reaction that can lead to end-stage renal disease. So glomerulonephritis is an immunologic process. it's an inflammatory process that target our glomeruli, causes inflammation in there and issues with the glomeruli. Usually caused by group strep A, usually 2 to 3 weeks after the infection. Signs and symptoms include edema, hypertension, oliguria, hematuria, proteinuria. These are the signs and symptoms. Diagnostic include labs, CT scan, ultrasound, renal biopsy. So we always please remember that ultrasound is the best diagnostic test for any kind of kidney injury, because it doesn't use any dye, so it doesn't cause any damage to the kidney, but it still give a lot of information regarding the patient status. Care: rest, restrict sodium and fluid, diuretic, treat the hypertension, no protein to very low protein, then antibiotic. Group strep A, short throat. CT scan can be done with or without contrast media. If contrast is used, ask about self-histology. Have the patient NPO for 4 hours. Tell the patient that contrast makes them feel warm and flushed. Have them hydrate very well afterwards. Antibody proteins are produced in response to something bad. White blood counts is high and protein is high because of the infection. Protein is running through the kidney, causing damage. Decreased GFR, causing proteinuria. Fluids leads to, we need to measure INO, and patient is retaining fluid in this case. Protein can lead to more damage, so give mostly carbs and fats. So that's why when we care for patients with glomerulonephritis, we do not give them a lot of protein or very little protein, because protein molecule is very big, and glomerulonephritis, they have little hole in there. And when they have to filter out the protein, it causes damage to them. So less protein, less work for the kidney. So that's why we give mostly carbs and fat when we care for patients who have glomerulonephritis. All right, so it is a glomerulonephritis is a rapid progressive disease. It associated with ARF, rapid loss of renal function, need prompt recognition, treatment, correct any fluid overload, rest, diuretic, decrease protein in diet. Chronic end-stage glomerular inflammatory disease, proteinuria, hematuria, slow down development of uremia. Treatment: supportive and systemic care, can't stop it, can't reverse, keep them from going into fluid overload. So chronic, the management is the key. So for glomerulonephritis, please be alert if the patient say they have tonsillitis or strep throat recently. That may help us to indicate what is the cause of the issues. And it's all about volume overload. And again, increased blood pressure, edema, and weight gain. So restrict or no protein. Okay, so it's important, we need to remember that. So in glomerulonephritis, the patient will be in an overload, they're retaining fluid, and we need to not give them protein. And strep A is usually the cause of the issues. All right, before I'm moving on, is everything okay? Everyone doing okay? Do you guys want to take a break, or do you guys want to keep going on? Keep going. Okay, I have one respond. Can someone else respond one more? So I have at least the majority. Thank you so much for responding. Okay, I'll keep going. So nephrotic syndrome. Nephrotic syndrome is also a intrarenal kidney disease. The pathophysiology of nephrotic syndrome is glomeruli, excessively permeable to plasma protein. Massive proteinuria leads to low plasma protein and tissues edema. So Basically, what it means is that the glomeruli, when the patient is having nephrotic syndrome, their glomeruli is so permeable to the protein. So the hole is so big now. It's so damaged and big, so that all of the protein molecule that our body have, when it comes to the kidney area, it will just go out, it just flow out. So we will be leading to low plasma protein inside our body. And whenever we don't have the protein inside our body, we cannot hold the fluid, the volume inside the vascular space. So it will leaks to other spaces, the interstitial places, therefore lead to tissues edema. So clinical manifestation include low plasma proteins because it is in the extracellular space tissues. That's what I meant, I'm sorry, extracellular, not interstitial, extracellular space. A nasakar, super swollen, but low blood pressure, fluid is shifting into extracellular space. Basically, we have the fluid inside our vessel and the fluid outside our vessel, our cells. So if the fluid is not inside our vessel and it leads to the outside of our blood vessel, it will lead to swelling. And when the fluid leaves our blood vessel, it leads to low blood pressure because we don't have enough volume inside the blood vessel anymore. I hope that makes sense. Hyperlipidemia, because decreased protein causes liver to mass produce cholesterol. So whenever the liver sends in our body that we don't have enough the protein, it will go to a state where it's produced a lot of cholesterol, and the patient will end up with hyperlipidemia. And then foamy urine because of the protein. Whenever you guys look at the patient urine inside the hospital, when you guys empty and it's super foamy, it's have like a lot of bubble and it's very like foamy like look. It means that the patient has a lot of protein inside the urine, and whenever protein is inside the urine, it's not good. The urine should not have protein in it in a normal healthy person. All right, intrarenal problem, the glomerulus can't hold protein, so the body is peeing out a lot of it. This causes low albumin and edema. And nasaccar is severe edema, foamy urine because of the protein loss. All right, nephrotic syndrome, nursing scare, resolve around fluid overload. So daily weight, I&O, measure girth, meticular skin care. Skin is very thin because of all the swelling. So high risk for skin integrity issues. We need to avoid trauma, monitor effectiveness of the diuretic, one more urinary output, monitor dietary status, give protein. Lower sodiums, high protein diet. So this nephrotic syndrome is different with the glomerulonephritis. The reason is because in glomerulonephritis, we still retaining the protein. In nephrotic syndrome, we're peeing out all our protein. So that's why in glomerulonephritis, we give a low to no protein diet. In nephrotic syndrome, we give protein in their diet. So this is so important to remember because it will be on the exam, okay? Infection control, and then we give albumin. Albumin is a protein. Corticosteroids decrease proteinuria. So albumin help increase blood pressure, increase protein, move back into the vessel, which will decrease edema. Then give diuretic, so it will even everything's out. Water lovers albumin, it will follow it anywhere. So yes, it is very important. So albumin is present in our blood vessel, and whenever we don't have protein, which means we don't have albumin, the water will not stay in our blood vessel. It will leak out and then causes issues. So if there's a question regarding evaluation for giving albumin, how do we know that the patient is responding to the treatment? It will be increased blood pressure. Their blood pressure will increase back up. All right, obstructive uropathies. So this is the last part, which is the C part, the post-renal injury part. So obstructed uropathy, basically it's blocking or impeding the flow of the urine. This include renal calculi. Clinical manifestation include flank pain, hematuria, dysuria, urinary frequency, and renal colic. So flank pain is highlighted because it's a hallmark for all of the kidney issues. So whenever we have a pain in our flank groin area, yes, it's kidney issues most of the time. Diagnostic include ultrasound, underscore, X-ray, serum calcium, uric acid, renal stone analysis. Care, we have control pain, prevention, hydration, moving around, limit sodium and calcium. Strain all the urine. The reason why we strain all the urine, straining the urine basically means that we tell the patient to pee into a strainer so that we can see if they passing any stone in it yet. So if it not passed, the stone is not passed, we do cystoscopy, lithotripsy. Lithotripsy, which basically means break stone up. It is a non-invasive procedure. It's like a medication that the patient take, and it helps breaking the stone up, and then surgery. Post-renal problem, if there is a stone blocking the exit of the urine, then it creates a backflow, dilation and extension of the ureter, and will lead to nephrosis. On diagnostic, avoid contrast because the kidney are already being damaged and the person can't really pee out media. Straining all the urine so you can check if the stone actually passed. The treatment, so because it's a blockage, so we have to remove the blockage, and we can give them Flomax, hydrate, lithotripsy. Remember, lithotripsy is important to remember because it helps to break up the stone, and Flomax it's help with the patient, especially who in PPH, which is the benign prostatic hypertension, hyperplasia. Yeah. Severity depends on location, duration, urinary status, infection, and pressure. Note, if pain subsides, the stone may be gone. Key to prevent is hydration. Remove blockage by giving Flomax to help relax the ureter to pass the stone more easily. Tell patient to hydrate to help small stone move with fluids when peeing out. Lithotripsy break up the stone and they get washed out. Look for the stone fragments in the urine. Complication of lithotripsy is hemorrhage, infection. The reason why it can cause hemorrhage is because when the stone is break, it can lead to this small fragment of the stone to be sharp. And when we pee out because of the high pressure, this fracture can cause damage to the urethra and then causes hemorrhage. And then whenever there's an open entries for the bacteria, which is the bleeding site, it can lead to an infection. So you'll be looking for the sign symptom of hematuria. So this is also important to remember. Hematuria is okay at first, then pee should come pink, then normal. So it is normal for the patient to take lithotripsy and have like bloody urine at first, but then after that you should see the improvement of the urine color. If the patient still have cochlear pain and bloody after many tries, we need to report that to the doctor. We also need to encourage fluids again after procedure so the fragments can be washed out. All right, so that's it for like all the theory for today. We have a couple of the questions. Would you guys like to to take a break and then we come back. I have a question. Can you explain the difference in protein in glomerulonephritis and nephrotic syndrome? Yeah, sure. So the difference between the glomerulonephritis and the nephrotic syndrome is that the glomerulonephritis, we don't lose the proteins. That's why we don't give the protein diet to the patient. Glomerulonephritis. So the glomerular is what helps filtering the toxin and then producing urine in our kidney. And in glomerulonephritis, this glomeruli is inflamed, but it doesn't cause issues with losing protein. So that's why it's we don't give protein to these patients. We give no protein, very low protein, because protein is a big molecule and it can cause more work for the kidney, and the kidney is already dealing with inflammation of the glomeruli. So we need to give them less work by not giving them the protein diet. Yeah, so, and then we have nephrotic syndrome. Nephrotic syndrome is basically it's happened at the same glomeruli. However, in this stage, the glomeruli is not inflamed. In this stage, the glomeruli it's just very permeable to the protein. So the glomeruli have this little hole, and this little hole, when it is supposed to be small, so that the protein cannot pass through the hole and go out of our body into our urine. But in nephrotic syndrome, this hole getting so big that the protein can easily go through the hole and go into our urine. So that's why we're losing the protein. And for that reason, we give them a high protein diet to replenish the protein that we are lost, even though protein is bad for the kidney. Is that make sense? I hope it does. Thank you. So for basically for those, we just have to really learn the thing that I said, the hallmark that I said, and the diet that we give the appropriate diet. Okay, so I have a few questions. So let's take a break and then we come back and then we do some of these questions together. So right now I have 5. Let's take a 5-minute break and then we come back. It's just a few questions, okay? We meet again at 5:05. Thank you, everyone. All right, hi everyone. So I have 5:05. So let's come back and let's do some questions together. So first questions I have is a client who had cardiac surgery 24 hours ago has had a urine output averaging 20 ml per hour for 2 hours. The client received a single bolus of 500 ml of the IV fluid. Urine output for the subsequent hour was 25 milliliter. Daily laboratory results indicate that the blood urea nitrogen level is 45 and the serum creatinine level is 2.2. On the basis of this finding, the nurse would anticipate that the client is at risk for which problem? Perfect, thank you. So I have 2 responses. It's acute kidney injury. So yes, this is a sign of acute kidney injury. The client undergoes cardiac surgery, is at risk for renal injury from poor perfusion, hemolysis, low cardiac output, or vasopressor medication therapy. Renal injury is signaled by decreased urine output and increased blood, BUN, and creatinine levels. So the normal level of BUN is 10 to 20 or 6 to 20. and creatinine is 0.6 to 1.2. For males, yeah, the client may need medication to increase renal perfusion and possibly could need peritoneal dialysis or hemodialysis. No data in the question indicates the presence of hypovolemia, glomerulonephritis, or urinary tract infections. All right, next questions. We have the client with acute kidney injury has a serum potassium level of 7. The nurse should plan which actions as a priority. All right, so let's see. Say select or apply questions, okay, guys? Okay, so what will we do when the potassium level is too high, out of range? Okay, so the answer for this question is we have to place the client on a cardiac monitor. Then we have to notify the doctor immediately. And then we review the client medication to determine whether any content or whether any that contain or retain potassium. We need to put them on the cardiac monitor because potassium, if it out of range, it will causes dysrhythmia and issues with the heart rate. And so the normal potassium level is 3.5 to 5. A potassium level is 7 is very highly elevated. The client with hyperkalemia is at risk of developing cardiac dysrhythmia and cardiac arrest. Because of this, the client should be placed on a cardiac monitor. The nurse should notify the healthcare provider and also review the medication to determine whether any contain potassium or are potassium retaining. The client does not need to be put on MPO status. Fluids intake is not restricted because it contributes to fluid overload and would not affect the serum potassium level significantly. All right, next questions we have. The nurse is assessing the patency of a client's left arm arterial venous fistula prior to initiating hemodialysis, which finding indicate that the fistula is patent. This question is pure message 1 content. So what do you guys think is the answer for these questions? All right, I have one answer. Thank you very much. Awesome, thank you. So the answer choices for this one is indeed the number 1, palpitation of a thrill over fistula. So the nurse assessed the patency of the fistula by palpating for the presence of a thrill or auscultating for a bruit sound. The presence of a thrill and bruit indicate the patency of the fistula. Enlarged visible blood vessel at the fistula sites are a normal absorption, but are not indicative of a fistula patency. Although the presence of a radial pulse in the left wrist and capillary refill less than 30 seconds in the nail beds of the finger on the left hand indicate adequate circulation to the hand, they do not assess the fistula patency. All right, next question. We have the nurse is reviewing the medical record of a client with a diagnosis of pyelonephritis. Which disorder, if noted on the client's record, should the nurse identify as a risk factor for this disorder? Okay. That's a really good guess. Yes. So yes, it's diabetic mellitus. So risk factors associated with pyelonephritis include diabetes, mellitus, hypertension, chronic renal calculi, yeah, UTI, stone. The reason why the diabetes mellitus is because, as we remember, pyelonephritis is the infection infection to the kidney. When the UTI in the bladder has gone untreated and gone bad, it moved to the kidney. Then it becomes pyelonephritis, and patients who are diabetic mellitus, their immune system is low and they prone to a lot of infection. So that's why this is the perfect correct choice for this answer for these questions. All right. So next week we will going over patient with GI issues, and then we're gonna have to do an exam review. So thank you so much, everyone, for coming today. Do you guys have any questions or anything that you guys would like to ask me or would like to talk before we end the meeting today? No? Well, I hope it was a helpful section, and good luck to you guys tomorrow. Feel free to leave. You're welcome. Thank you so much for attending. You're welcome. Oh yes, I definitely put the code again. Thank you so much for reminding me. Okay, this is the sign code. Thank you. Thank you for attending. All right, I'm gonna end the meeting.